I want to welcome everyone to this webinar being given by the American Board of Otolaryngology Head and Neck Surgery. So I'm Gaelyn Garret. I'm the current president of the board, and I am joined by three of my colleagues, two of whom are current directors on the board. Dr. Timothy Smith, who is at OHSU in Portland, Oregon. He is actually the chair of our assessments committee, which is basically that committee is in charge of all of the assessments that we give, including this one. And then Ron Kuppersmith, who is chair of our continuing certification committee out of Texas. And then Brian Nussenbaum, who is the executive director of the board, and he is a full-time employee of the ABOHNS in our hometown of Houston. That's where the board basically is headquartered. So I want to thank everyone for taking this time to be with us tonight. This is hopefully one of several webinars that we will be giving, discussing our new oral board exam format. I know we're excited about it. I know you are probably less excited about it and more anxious about it, but hopefully after hearing some of what we're going to present tonight, some of that anxiety will be allayed. I also hope that everyone was able to watch the video of the presentation that we gave at the Academy here in Nashville not too long ago. And that presentation, I think, gave a lot of the background history about why we are doing this. We're not going to go into great detail about the why tonight because, at this point we are moving forward. But certainly, we are all happy to answer any questions later on about that. I also want to thank everyone for sending questions in ahead of time. That was very helpful, and we will be incorporating those questions throughout the presentation. And we're probably not going to get to everyone's questions. We've tried to group the questions as much as possible. If you feel like your question was not answered, feel free to reach out to us later. We also have a question and answer option during the webinar, and we will either answer those as we go by typing in. Now, Dr. Kuppersmith or Dr. Smith will be doing that for the most part. We may, depending on the type of question, we may answer it verbally during the presentation. But again, we may not get to all those questions as well. We want to try to answer as many questions that will have the biggest impact to the majority of the people who are going to be participating. So I think with that, we're going to go ahead and get started with a relatively brief presentation, because we want to give some opportunity for some questions later on. And we are going to try to be very strict with our 1 hour, because we know this is a busy weeknight for everyone. So we want to be respectful of your time. So, all right, I'm going to hand it over to Dr. Nussenbaum. Oh, do you want to do the mission statement? I'm sorry, forgot the slide. Okay. I'll do the mission statement. So, this is the mission statement that we have for the board. And I think, for us, it's always good for us to be reminded every time that we talk about our board activities about what our mission is. And, basically, we exist, one, to be a profession that is self-regulated. But importantly, we are here to serve the public and serving our patients as well. So everything we do is really grounded in this mission statement. So, it's very brief, but I think it's very to the point, and hopefully will help guide everyone as we move forward. Now I'm going to hand it over to Brian.
Thanks so much, Gaelyn. As Dr. Garret mentioned, we're not going to extensively go into the why of the change to the new oral exam format, but we did want to review some of those details. This is Miller's pyramid, which was described in 1990. This is a commonly described and used framework for assessment of clinical competence. You could see in this pyramid concept, there's the nose, which is the foundation, knows how, shows how and does is at the top of the pyramid. And the knows and the knows how are assessments of cognitive knowledge, whereas the shows how and does are assessments of performance. And in terms of the knows, these are typically knowledge tests such as multiple choice question, written exams. Just because a written exam is at the bottom of Miller's pyramid in the knows, it doesn't mean that it's less important than something that's higher up on the pyramid. But really, this is representative that this is the foundational knowledge one needs to have in order to move up to higher levels of Miller's pyramid. This knows how is our applied knowledge tests, such as our previous oral exam in the old format, which was really an applied knowledge examination, not an examination in performance. The shows how these are assessments of standardized performance in controlled settings. An example of this would be an objective structured clinical exam, or what are called OSCEs. And then the does is the performance in actual real world practice, and this is the does. And with the movement to the new oral exam, we want to move from an applied knowledge or a cognitive knowledge assessment to determine certification to a performance assessment, and felt that that we really needed to be at the top of Miller's pyramid in the does area, your performance as a candidate for certification in your real world practice. So moving forward, the written exam will remain the foundational knowledge assessment. As you know, this is an exam of 300 multiple choice questions. This is a way for the board to assess and evaluate your depth and breadth of knowledge in the entire specialty in a foundational way. The timing for the written exam will remain unchanged, being shortly after the completion of residency. And we put here for most because the great majority of candidates do take the written exam very shortly after completing residency. But there are some that don't, that for a variety of reasons might wait a year or two to take the exam. And also there are individuals who are eligible for certification that are international medical graduates that go through a different pathway towards to become certified. And so their residency may have been many years ago. So that's why we say for most that the written exam will be taken shortly after residency, as it currently is, and will remain. The oral exam will be an assessment of the skills required to safely practice otolaryngology head and neck surgery. And once again, rather than in an applied knowledge assessment, in a performance assessment of what you are doing in your practice as an otolaryngologist head and neck surgeon. The content will include only cases from your practice, both surgical and non-surgical cases. And once again, the assessment of what you're actually doing, not what you hypothetically might do in the old format, where you're asked unknowns and you don't know what's going to be asked of you, but you're asked hypothetical situations and how you would manage those situations. This is what you're actually doing in practice of what will be assessed. As candidates, you could initiate the application as early as during your first year of independent practice. Independent practice meaning that you are completely finished with all training in the specialty, including fellowship training, and including whether that fellowship training is ACGME accredited or non-ACGME accredited. We do not, in terms of the cases we're evaluating you on, if you're not in independent practice, if you're still in a training environment, those are not patients you're independently taking care of. And a variety of surgical practice will not be required. The reason for this is that we want to assess what you are actually doing in practice. And certainly the board does not want you doing cases in your practice that you would not be doing otherwise. In other words, we don't want you to be doing various different surgical procedures just to get them on a case log list. So a variety of surgical practice will not be required. In terms of eligibility requirements for the oral exam, you need to first pass the written exam. That's the first step. And you need to, once again, as mentioned, complete all training, including all fellowship training, including ACGME, and non-ACGME. You need to be practicing otolaryngology head and neck surgery with independent autonomous practice with an unrestricted medical license in the US or Canada. And if you are eligible for certification by the board and you went through the Canadian pathway, as described in the Canadian pathway, you need to be a fellow of the Royal College of Physicians, Surgeons of Canada in good standing. You do need to have operative privileges at a hospital or certified surgical center, at least one. All cases must be submitted from practice sites either in the United States, from a US military facility. Now that military facility, it could be in Germany or Japan, it could be international, but it does need to be a US military facility if you're in the military, or in Canada. And the certification process, in other words, passing the written exam and passing the oral exam, must be completed by the end of your 7th year after becoming eligible for board certification. This used to be by the end of the 5th year, but this was recently increased to 7 years to accommodate for this new format. So if we look at the application process, as a candidate, you would apply online. With that application, the board would confirm that you're eligible for the oral exam. As part of that process, you'd be completing a HIPAA business associate agreement, which is signed by the candidate, by the board, and by the technology vendor that we are working with to collect your case log information. Once your application is approved, you would get access to the case log portal to submit your cases online. And there will be a peer review process also that we'll briefly touch on this evening. And then we did want to mention the fee structure. So prior to the movement to the new oral exam, there was one bundled fee of the written exam and the oral exam. As you know, we've unbundled that at this point. So for those of you who took the written exam back in August of this year, you didn't pay the full amount, you just paid the written exam fee. And then the oral exam fee, though, will be an application fee when you initially apply, and then an exam fee shortly before taking the exam. If we look at the fee structure for 24-25, as you know, when you took the written exam in earlier this year, the price was $1,730. And in terms of the oral exam fees, the application fee for those of you who will be applying shortly will be $800. Now, we have received questions of, what is included in the application fee. So this is the credentialing process by the board, the entering, the access to the case log portal and that case log process, the peer review process, the board's review of ultimately all your submitted materials, and the selection of the cases for your exam. So there's actually a lot being done, a lot of activity for this application fee of $800. As I mentioned, shortly before the exam, there will be a fee to take the exam itself, and that fee will be determined at a later date. In terms of the application process, we anticipate that this will be opening during the week of January 8th. You will access the application through your ABOHS portal. So when you log in under Managed Certification, if you click that little circle and expand the accordion, there will be an option to click to apply for the 2025 oral exam. And the application process will be open for 5 weeks. In terms of, you might ask, well, what is actually going to be involved with applying? We do not anticipate submitting an application will be an onerous or time-intensive process. This should be fairly straightforward. You will need to complete attestations that you're currently in independent practice, as will be defined on that screen when you attest to that. And then also you will need to complete an attestation regarding that there are no current disciplinary sanctions or actions that you have on your medical license, on your ability to practice otolaryngology, head and neck surgery, et cetera. And the attestation regarding disciplinary sanctions is something that, even with the prior oral exam, was something that all the candidates did. You will need to update your contact information. We also will ask you to verify and update all your medical license information in the US and Canada. And so it would be helpful before you start the process to just make sure that you have that information available. You will need to list all your sites where you provide clinical care. This is something you might want to gather in advance, just the address and phone numbers of your hospital, your medical office, et cetera. You will need to sign the candidate agreement, and also this is the point where you would sign a HIPAA business associate agreement. You cannot start the case log process without signing this business associate agreement. This HIPAA business associate agreement is a standard form that's used by all of the boards that involve case logs and cases from practice as part of their oral board exam. And then you would pay the application fee of $800. Now, we did want to comment on the non-operative pathway. We did previously communicate that there would be an option for a non-operative pathway for those individuals that were deciding that they did not want to operate as part of their practice right out of residency. And after considerable further discussions, the board has decided that this will not be offered at this time. If you have already reached out to me that you are interested in this pathway, please just reach out to me again to remind me. But certainly, if you have not reached out to the board yet and you were planning on applying on the non-operative pathway, please reach out to the board. At the end of the presentation, there'll be ways to reach out to us because we'd like to initiate and have a conversation, a discussion with you about what options there might be for you to still proceed ahead with obtaining board certification. Gaelyn, this might be a good time for us to address some of the frequently asked questions about the eligibility and application process that were submitted in advance.
Yeah, so and there was actually, before we get to that, there's just a question up on in the question and answer about if you start operating at a new location after applying. So I think it depends on when you start at that new location, but we want to include consecutive cases. So Ron, did you want to provide another answer or something?
No, I was just marking it. I was just marking
okay, got it. So we want all the cases, and the other thing is we need follow-up. So yeah, but that's a good question, and I would appreciate maybe if that's one where you would want to reach out to us if that happens and let us know the details about that. So all right, so
I think the question also is it a new location in your existing practice, or are you switching practices? Because I think that I would imagine that if it's a new location in existing practice, it's probably not a major issue. But changing practices is something that we think may be difficult in order to get all the records and everything that we need.
So, all right, Ron, do you want to tackle the questions on that are up on the slide?
Sure, thanks, Dr. Garret. So the first question is, how does this affect the timeline for those taking additional certification exams, such as the ABO-HNS sub-certification, ABFPRS, and ABPS? And so you cannot start collecting cases until you're an independent practice. And so you would have to be done with your fellowship or sub-certification training period before you could apply and start to collect cases. So that's why we extended the eligibility period from 5 years to 7 years. And there'll be more information later that comes out related to how the timing of sub-certification, for the sub-certifications that we offer play into this. And so you'll have to do primary certification first, complete that process, and then you'll go through sub-certification. And then the second question is, how does this affect the timeline for international medical graduates applying through the specially qualified pathway or Canadians applying through the Canada pathway? So it really shouldn't affect the timeline in terms of eligibility. Once you've completed one of these applications or pathways, then you would be eligible to take the certifying exams and to apply and then start collecting cases.
Mm-hmm.
So the clock would start once you're approved through those pathways.
Ron, if I might just make a brief comment about the ABFPRS, the American Board of Facial Plastic Reconstructive Surgery. The president and executive director of that organization have already initiated conversations with the board about how our process change might have impacts or affects the certification process through ABFPRS. I would encourage you to reach out to Lori Worth if you're in that situation, and ask them directly how this affects it. My understanding from our conversations is that rather than requiring to be board certified with ABO-HNS at the time of taking their certification exams, they're going to require passing the written exam only, not the written and the oral. That's my understanding, but the best thing to do would be to reach out to the ABFPRS and ask them that question directly and get an answer from the primary source. If you exited otolaryngology head neck surgery residency and entered a residency, an ACGME accredited residency program in general plastic surgery, in other words, you have 3 to 5 more years of training, and you're looking to also get board certified with the American Board of Plastic Surgery, please reach out to us and initiate a conversation discussion about how that might impact things.
All right. Tim or Ron, do you want to answer the question that's in the chat box?
I think Ron just got that one, Gaelyn.
Okay. Well, I think it was related to pediatric CPO. But yeah, basically, yeah. I mean, basically, you have to complete your primary certificate for otolaryngology before you can go down the sub-certification pathway.
Right. And then you can't start collecting cases until you complete your fellowship and you're in independent practice.
Yeah. Okay.
And it's then the answer, Ron actually typed out an answer, and it's under the answered questions in the chat. That's what I meant, Gaelyn. I didn't.
Oh, I didn't see that. Thanks. No worries. All right. And then just also, so you know, everybody who's on, if we see a question that we know we're going to be addressing later on, just kind of stay tuned and hope, like this one that just got put up, I think we're going to answer it. Tim, you want to answer about independent practice?
Yeah, there've been a lot of questions about, what represents an independent practice. I think Brian defined it really well, but the way I'm thinking about it is it's an unsupervised practice after all training in the realm of otolaryngology head and neck surgery. That's residency and fellowship training in the realm of otolaryngology head and neck surgery needs to be completed. So if we take the first example here, having a general oto practice as an attending within, let's say, a non-ACGME accredited fellowship program, there's lots of those going on. Yes, you may have an independent practice within that fellowship, but you've not completed your fellowship training yet. So no, you would have to wait until the fellowship is complete and you start your independent practice after the fellowship is complete. Locum tenens position. Most of these don't suit this process well because most locum tenens are weeks to a few months, generally speaking. So that means that the candidate would be moving their practice around. And remember, after you submit your case log with all of your surgical cases during the 9-month period, we are going to select 10 of those cases and ask for more detailed records. And so if you've left a practice site and you've moved on to another practice site, you may no longer have access or ability to get the information that we need. So for the most of the time, locum tenens is not going to work with this particular process that we have set forth. If you think you have a special circumstance, please reach out to us. Working part-time, on the other hand, should really have no substantial impact other than can the candidate accrue the minimum number of cases during the 9-month period? And the minimum number of surgical cases is 40. And it's our estimation that the vast majority of folks, even working part-time, will be able to accrue those cases. So working part-time seems to work just fine with the processes that we've laid out here.
Yeah.
Okay. And I know Dr. Smith brought up some specifics about case collection, and we're about to get into that. So you didn't have to write all that down. We're going to give you some more details coming up.
And Gaelyn, if I could just say real quickly, we have received a lot of questions, not only for the webinar, but also before the webinar, that regarding the timelines on sub-certification, and we'll be communicating more information about that in the coming months in terms of those details.
All right.
So if we go on to the next step here, so one has meets the eligibility requirements and your application is approved. At that point, you move to case collection and peer review. We're not going to be commenting much on the peer review tonight, other than saying that this will start several months into the case collection period. And it'll be similar to the process that's used by hospitals, ambulatory surgical centers, your practices regarding, getting credentials. It'll be a similar process, and more details to come in the future about that. More immediate, though, is going to be starting the case collection, and we'll get into those details this evening. We anticipate that the case collection period will open in early to mid-March of 24 for those of you who are applying for the 25 exam. The duration will be 9 months long, so from March through December of 24 for the 25 exam. In terms of if there are special circumstances, or if you're in the situation of parental, caregiver, or medical leave, we will try our best to make accommodations if necessary. As Tim had mentioned, we anticipate even if you did not work for the full 9 months, that many of you will still be able, many if not most, will still be able to make the minimum case submission requirements. But certainly, it's early proactive communication is important, and we will, if necessary, we'll try our best to make accommodations as needed for these situations as needed. In terms of the case collection, the case logs must include all consecutive surgical cases over the 9-month period from all hospitals, ambulatory surgical centers, and offices where you perform procedures. So in other words, if you do a procedure in the office, such as a balloon sinuplasty, just because you're not doing it in a surgical center or a hospital, if you do it in your office, that would count as case. So wherever you're doing those surgical procedures, they need to be submitted. Now, there needs to be a minimum of 40 operative cases to be eligible for the exam. With that said, there were several questions that were submitted in advance that implied that the thought was that once you got to 40 surgical cases, you stopped submitting cases. That is not the case. Some of you might have 45, some of you might have 150. Just depends on your surgical volume in terms of the practice that you have. So once again, in the 9-month period of time, all consecutive surgical cases from any of these clinical care environments. We do also want you to be submitting 40 non-operatively managed patients that you saw and took care of during that time. There is an important, the practice of our specialty is not only surgical, but it's non-surgical also. There are a lot of patients who are medically managed and never have surgery, never get scheduled for surgery. And certainly we do want content for the exam to be evaluating and assessing how you are non-operatively managing patients in your practice. So there will be a list of qualifying ICD codes that are permissible for these 40 non-operatively managed patients to put in your case log. And the reason for having qualifying ICD codes is we certainly don't want you putting in patients that are in your office for a serum impaction and or some other codes that we really would not be testing you on. So so there is not a limit for the surgical cases. Once again, all consecutive cases in 9 months, but for the non-operative patients, there will be we would like 40 of those patients. In terms of the definition of a case during case collection, each case is a unique patient, no matter how many procedures you've done on that patient, whether that's staged, reoperative, et cetera. So for instance, if you did a hemithyroidectomy and it turned out that nodule was malignant, you take the patient back to the OR a few weeks later for completion thyroidectomy, that is one procedure. That is not 2 procedures. So think about it as the number of cases is the number of patients that you've operated on. There's no unbundling allowed. So a case is all portions of that operative session. So for instance, if you did a total laryngectomy and bilateral neck dissections, that is not 3 cases, that is 1 case. If you do surgeons as a co-surgeon with one of your practice partners, that can be submitted, those cases, as long as you as the candidate is a billing surgeon. In terms of the how you would put the cases in, you'll be receiving, once your application is approved, you'll be receiving access to the case log portal through the board's website. So you would log into the board's website, into your portal, and there'll be a tile there for you to click to access the case log portal, which you'll have a separate username and password to access. We received a lot of questions of that in the case log process, what's going to need to be entered. And it really falls in the 4 categories: the patient information, the diagnosis and disease classification, information about the surgical procedure that you did, and if there were any complications that occurred. We recognize that complications might not be recognized right away. They might be recognized, days or maybe even weeks later. And for that reason, for each of these, each of the patients you place in the log, you could go back at any time and click edit and re-enter that record and update information as needed. We have been user testing the case log portal and making actually currently a lot of changes to the case log portal based on really robust user testing from many of the board volunteers. One of those questions we asked on the initial survey is, how long did it take you to input a case? And 70% of the individuals said less than 5 minutes, 30% said between 5 and 10 minutes. Not a single individual who's been user testing the portal has responded that it took them more than 10 minutes to submit a case. So we do not expect, while there's a fair amount of information you'll need to input, we do not anticipate that this will be an onerous process for you to enter this information on all the patients you operate on and those 40 non-operative patients. Gaelyn, this might be a good pause moment to review the questions about case logs that were submitted in advance, the frequently asked ones.
Yep, and just so you know, I appreciate Ron and Tim answering questions in the chat section. Those are all good questions, but we do have some that were submitted beforehand. So I get Ron, you want to tackle this first set? You're on mute, Ron.
Sure. So the first question is, can the cases be from different states? And I think the answer to that is yes, as long as it's within the same practice setting, the same job. So there are places in the United States where people practice in multiple states, and so that shouldn't be a problem. The second question is, for international medical graduates on the specially qualified pathway, can cases be included that were done prior to becoming eligible for board certification? And the answer to that is no, because you have to go through the application process, and then the case log period will be a very specific period of time, which would occur after that. And then what happens if I do not get enough cases, or if my case log is not approved? In that case, you will not be able to sit for the oral examination during that cycle. And depending on what the issues are, you will most likely have to apply in a future cycle. And you do have the 7-year period after completing training or becoming eligible in order to meet that qualification.
I know there was one that in the chat that you wanted to answer, but I think it's included in maybe these two.
Yeah. Yes, it was a question that was asked prior as well. So will the information submitted for non-op managed patients be different? And there will be, it will largely be similar, but there will be some differences. For instance, on non-operatively managed patients, we won't need information regarding CPT codes, surgical complications, anesthesia complications, but much of the information will overlap. And then the second question was, do the non-operatively managed patients need to be consecutive or from a single practice site? This is an area we're still discussing, but I can say that I believe at this stage that the cases, the non-operatively managed cases, will need to be consecutive cases during that 9-month period. So therefore the candidate at some point during that 9-month period will say, okay, here's the day where I start collecting my 40 non-operative consecutive cases. And as soon as you have 40 consecutive cases logged, then you'll be finished with that. But we will follow this up with very specific instructions. That's what I believe the procedure will be. And then the second part of that question is, do these have to be from a single practice site? Well, again, it depends on what you mean by practice site. Some people see clinic in this part of town in the morning, and then in the afternoon they're seeing clinic on this part of town. Certainly they could log those as consecutive cases. If we're talking about moving practice sites during the course of this period, that's probably not going to work, meaning moving your practice from one state to another state and having practice sites that way doesn't really work for this particular system. We need to have you located in generally one environment during this 9-month period.
Yeah.
I think that's all I got, Gaelyn, on those.
Okay, sounds good. All right.
So once the case log and peer review process are completed, and if your application is approved, you would move forward. That the board would be communicating with you that you're approved for examination. And during that process, the board would be selecting of the cases in your case log. So let's say you had 100 surgical cases and those 40 non-surgical cases. So you'll have 140 cases, and the board would communicate with you which of the cases were selected for your exam. So you will know before your exam, you'll know what cases are going to be included on your exam. Now you'll see that the case log and peer review approval process and the case selection process we have here listed as 5 months. If we look at the other boards that in the ABMS community that use case-based exams for the oral exam, this time period is anywhere from 3 to 6 months. And for this first go around, we felt that it was probably safest to just plan on this process taking 5 months. In future years, it might be a little quicker or maybe a little longer, but we thought that this would be a good place to start given the length of time it takes other boards to go through this process. And once you're notified that everything's been approved and these are your cases that will be included on your exam, you will be asked to submit materials, more detailed materials on those specific cases selected for the exam. If we look at, once again, the other ABMS boards that use cases from practice for their oral exams, the candidates typically have approximately 6 weeks to upload all the requested additional materials on the cases that will be included on their exam. For now, what we are anticipating that we'll give you 2 months to upload all the information that's requested. Now, what will be requested on these additional cases? So materials that your examiners will need in order to be able to evaluate and assess you on those cases that were selected for your exam. For instance, office notes, operative reports, radiology reports, informed consent forms, things like that. Now, will there be specific requirements for documentation? There will be some. And as an example, if you have a cosmetic case that you did, we will require that you submit as part of the materials, not during the case log, but if that case is selected for exam, we will require that you submit pre and post-operative photos on your cosmetic cases that you've done. More detailed instructions will be provided in terms of these details about what materials we will be asking you to submit. Once again, not for your case logs, but on the cases selected for the exam, and also what specific documentation requirements will be expected if we choose one of those cases for the exam. And then once you submit your materials, and then the oral exam happens. And in terms of the details of the exam, this will consist of 10 of the cases from your case log, a mix of both the operative patients and the non-operative patients on your case log that will be selected in advance and known to you of those 10 cases. There'll be 2 sessions with 5 cases per session. Each session will be 50 minutes long. So on average, 10 minutes per case. If we look at our other peer boards that do this, it's typically 9 to 10 minutes per case. So this is consistent with our peer boards that have been administering these types of exams previously. And there'll be 2 examiners per session. So you'll have a total of 4 examiners who are independently evaluating you in your practice. This new format will be back in person. We do feel that this format exam will be best assessed for you as candidates if we're back in person rather than trying to do this virtually on Zoom, particularly with the amount and degree of information exchange that's occurring during the exam session. The majority of the boards the great majority of the boards in the ABMS community that administer case-based oral exams have already gone back to the in-person setting for those reasons. In terms of ongoing activities, we are currently in the final stages of developing that application portal that I mentioned that we anticipate opening during the week of January 8th. We're also making excellent progress in developing the case log portal. We anticipate that will open during the week of March 11th for those whose applications are approved for the 25 exam. And there will be future updates communicated not only through the board website, but also by email. If you have follow-up questions or concerns, please reach out to the board office at this email address, oralexam, one word, @abohns.org. So once again, oralexam@abohns.org. We have received a few communications from individuals telling us that they got a bounce back and the email address isn't working, and it turned out they were using @abohns.com. So please remember it's .org. And also, if you would like to have a conversation with me, particularly if you have a special circumstance or if there are some details you'd like to discuss, please feel free to reach out to schedule a meeting to talk to me, and you would do that by contacting Michelle Ortiz, the ABOHNS Administrative Assistant at mo@abohns.org to schedule a meeting to speak with me. And Gaelyn, I'm going to stop sharing my screen at this point, and we have about 15 minutes to continue the conversation or answer further questions.
It looks like, Brian, there are several questions that are in the queue that we're going to go live. Yeah. And one person has been asking questions about whether they can submit a variety, the same cases over or could they submit 2 laryngectomies? And really, I think the answer is you're going to submit all of your cases during the 9-month period. So it's not, you can submit 5 laryngectomies, whatever you do, we want you to submit. The second question, Brian, maybe you can help with this one, is that, ABONS has extended the board eligibility interval from 5 to 7 years. And they're saying that many insurance carriers have an explicit requirement that a physician has up to 5 years to obtain board certification to maintain in-network status. Have these changes been discussed with insurance carriers to prevent lapses in coverage or reimbursement? And I Brian, it's my understanding that other boards have time periods that are out past 5 years as well.
Correct. It's something I think we could look into, but in the ABMS community, the board eligibility period is anywhere from 3 to 7 years, but many of the other surgical boards, particularly those that have longer case collection periods like neurosurgery, have up to 7 years. And so I'm a bit surprised to hear that, and I don't know if it's specific to otolaryngology or more general, but we could certainly look into that.
Yeah, I mean, I think if somebody has, documentation of that, we certainly would like to see that submitted so that we can look at it and address it. The next question is, not to be rude, but why was the traditional oral exam suspended when there are so many unknowns about the new exam process?
Yeah, so let me take that one. So, I know it appears there are a lot of unknowns and there are some details that we're still working through, but I will tell you that it is basically impossible to be considering 2 different exam types at once, number one. Number two, we feel like this new format is kind of where we need to be. And I hate to say it, but this group, unfortunately, is the inaugural group, and it has to happen at some point. But there are a lot of things happening behind the scenes that it would take us hours to kind of go over. But we don't want to provide information that is either incomplete or that it might change based on some resource type details. So, I think we feel very, very good about this new process. And I think the other thing is we're not the first board to do this. We have professional consultants that we're working with who have worked with the other boards who have been doing this for a while. So I think that this is going to be actually a very smooth process as we get through it. And I know it's daunting that we can't answer all of your questions tonight, but we will be providing as many details as it comes. We will be ready when the case log portal goes live in March. So,
and this has been years in the making.
It
was not a rash decision, by the board. It
Right.
was many years of discussion.
Brian, there's a question in the chat about when the oral exam might be in 2025. We know it's going to be late in 2025, but we don't have a month and a day scheduled for that exam as of yet.
Yeah, I think that the earliest would probably be September of 25. In terms of the timeline that I sketched out, if any of the attendees did the math in terms of the case log time, the months of the approval and selection process, and then the length of time to submit those materials, and then it really comes into mid to late. So I would estimate around September of 25.
Great. And then the next question was about how examiners are selected. And I think we would answer that by saying that the folks we have as examiners, whether it's under the prior exam process or the new exam process, are experts in delivering the examination. And as board certified otolaryngologists, even those of us who are subspecialized are capable of examining for the primary certificate. Now, there are some examiners that we speak with and we survey very carefully who don't necessarily feel comfortable examining in this realm or that realm, and we simply don't put them in this realm or that realm. So we take great care to make sure that the examiners are appropriate for your examination. I didn't get to read the next one, Ron. I don't know if you
so the next one says some physicians are employed in clinics that cross over state borders. How will that be considered? If you're in a practice and it crosses state borders, you'll submit the cases. I don't think, that will really matter. But if you do change jobs, the current thinking is that you'll have to reapply in the next cycle. I think that's kind of where we're currently thinking, but, details are subject to change. And the next one talks about if it's an honor system for submitting all cases in consecutive order, what if a mistake was made and cases were skipped? There is always a chance that we could choose to audit, anything and everything. And so if we find that people are intentionally, skipping cases that they're trying to hide from the board, that could cause some major professionalism issues, and also potentially result in the inability to become board certified. And so, that'll be part of the process.
There's a question about changing jobs in the first year, essentially moving practices in the first year. And, the challenge there is that this process we've outlined today has a few steps associated with it. And one of those steps is a peer review. And that peer review, of course, reaches out to colleagues, both in your practice, in your community, chief of staff of hospital that you work in. So we have that logistical issue that we need to face in these circumstances. And then second of all, you submit your case log, and then we need to select 10 cases that you're going to be examined on, and you're going to have to provide the board explicit information about those cases, including potentially CT scans, audiograms, other tests. You're going to have access to all of the records for these patients. So therefore, moving during the course of the 9 months where we are assessing your practice, it makes it infeasible, really, for us to carry through this process. Brian, I don't know if you can expand on that any further from what I've said, or if I've said that clearly enough.
No, I think you actually described that really well, Tim. And my understanding from my conversations with the leadership of the other boards that have been doing these types of exams for many years is that for the reasons you're describing, they don't allow that to happen. That that during that case collection period and during the exam, that while you're in that case logs, that it's just for the reasons you're describing, you're not able to change practices, and if you do, you wait till the next year to collect your cases until you're in a different environment where you'll be more stable and not changing jobs during the process.
And that's why we give 7 years after finishing training. I know, many of us are very used to, quickly getting through the next, step of whatever it is, and there being a specific sequence. But if you don't take the exam the first year you're eligible, you still have several more years that you can take the exam. Mm-hmm. And you're not penalized for taking it at a later point.
Yeah. And Ron, to your point, in the old exam format where it was applied knowledge, that there is some decrement of general knowledge in the specialty as you more specialize in a practice. But with this, you're being examined on your patients that you've actually taken care of. So if you do apply 2 or 3 years later, as you mentioned, Ron, you do have up to 7 years. Ultimately, you're being evaluated on the patients you took care of, not receiving unknowns potentially situations that you never see and never take care of in your practice.
All right, guys, we've got about 4 minutes. So let's, and just so you know, for questions, we are going to be collecting all of these questions. So we will do our best to answer them in, either in another webinar or in another format. So
there's a question about why can't the timeline be changed, and there's lots of logistical issues. It sounds like this person has an individual circumstance where they would prefer a different timeline, upon which we understand that you're probably just going to have, if you're going to be interrupted in your practice in that 9-month time period that we've outlined, you're going to have to wait for the following year to collect your cases. In terms of grading these assessments or determining, pass, fail for this examination, there are psychometrically valid processes that other boards have utilized, and we have access to all of that. We have a psychometrician who works for the ABO HNS, and he has worked with some of these other boards who do exactly this type of examination. We actually feel there are some strengths to this particular exam with regard to assessment, and that's one of the reasons that we are moving towards it. There's lots of information on the website. We're even setting up frequently asked questions section on our ABO website. So as you can imagine, we're gathering these questions, we're creating the FAQs, and trying to answer and put as complete of information as we can there. I didn't read the other ones. I don't know if you did, Ron.
There's one,
the
one I'm looking at, the bottom one, and I remember this question came up at the Academy meeting about military physicians not doing coding, and I don't think and asking if we've come up with a resolution around that yet, and the answer, I think, is no, we have not come up with the resolution to that yet, but more to come.
Yeah.
There's a question about the impact of providing this information over the 9-month period. We recognize the burden that this places on practitioners. We have tested our system, and we're meaning we've had volunteers from ABO HNS log cases for several weeks at a time, and we are, I guess I would say, fine-tuning our processes to try to make this as smooth and easy as possible. We recognize there's a burden here, but on the other hand, we hope that folks will recognize that we're moving to an assessment that has great advantages, we think, to the candidates as well as to the public, frankly. And so while change is hard, and you all are the first group to go through this change with us, we are absolutely convinced this is the correct direction for the board to move. We apologize for the additional burden that it might place on you. Others in the exam prior to this, they might have said it's a burden to study topics on parts of the practice that I don't even do within my practice. So now we're only going to ask you questions about your particular practice and your cases. So there's great advantage, I think, to the candidates in that regard.
So Tim, I think that was well said, and I think that's a good conclusion statement, because we are past 8 o'clock. But again, I know people are still putting questions in, but we will log these questions, and we will try. We are definitely going to have an FAQ section on our website that will be kind of a living document. So stay tuned, and again, we appreciate the concerns. It's never good to be the first change person. So but again, I think you will find that this is a worthwhile endeavor, and hopefully some of you will hopefully become volunteers or other involvement with the board down the road. So we really appreciate, and we appreciate taking time on Thursday night. So Any other, Brian, any other, or Ron or Tim, any other closing thoughts?
I don't think so. Let's let everybody get back to their families.
All right. Thanks, everybody. Stay tuned.
Good night, everyone.
Good night.
Good night.